All right, what questions can I answer for you guys?
So at the beginning of the last lecture, we were talking about gentamicin and how the babies are like bags of water.
Mm-hmm.
So your dose would be higher, and then later when you were talking about renal elimination, I believe you said that it would be lower than yours.
Yep.
So which one is it?
It's both. Okay, so the question is about gentamicin and how is that handled in neonates versus like in adult patients, right? So you're absolutely right. Small, tiny babies are basically just big bags of water, right? They have a lot of extracellular water, and that affects the volume and distribution of the drug, right? So that means that when I give a dose, so I give 4 mg per kilo of gentamicin to that little baby, because they have more water and the gentamicin is more water soluble, it's going to distribute out farther into the tissues, right? So that means, what is that going to do to my, if I were to do a blood draw, what does that do to that level? It'll be lower, right? Yeah, because more of it's out in the tissues than it is in the bloodstream, okay? That's why, basically what that means by a larger volume distribution.
If it's water soluble?
Yes.
I thought if it was water soluble, then it would be out in the tissue.
It would be, but because these guys have a lot of extra body water, they don't have as much fat tissue, right? They don't have a ton of fat, they don't have a ton of muscle. So because they have more body water as compared to like an adult patient, that's where all that drug goes to, right? So it distributes out farther, so the blood levels get lower as a result, and that's why we have to give bigger doses, right? Because again, the blood levels that you're looking for between an adult and a neonatal patient are roughly the same, right? But I just have to give a bigger dose because that drug is distributing out farther in the neonatal patient than you see in the adult. Okay, so that has to do with the dose. So on a mg per kilo basis, the neonates are getting a higher dose than adults are. If you're looking at the actual renal clearance, right, because gentamicin is exclusively eliminated through the kidneys, you're going to find that they, especially the preterm ones, right, and preterm is like what age frame, or what gestational age? Yeah, less than 37 weeks. So they're going to be, they're going to have more immature kidneys. They're not going to be able to process it as well or to filter it as well. So you're going to find that they have to be dosed less frequently because they hold on to the drug for longer, right? So for instance, I may give a higher mg per kilo dose for a neonate, but I'll end up giving it less frequently. So, so if you go to look at a neonatal dosing reference, you'll find like a term infant would get, say every 24 hours dosing. If they're preterm, they say like, less than 28 weeks, they'll get every 36 hours. If they're less than 24, whatever happens to be, it'll be 48 hours. Okay, so get a bigger dose, but less frequent administration.
So the timing is what's different.
Absolutely, right? Because you guys remember gentamicin is what type of antibiotic? Concentration or dose dependent or time dependent? Concentration dependent, right? So you want to give a big dose, get levels up high to kill the bacteria, and then it drops off, right? So you'll find that like for adult patients, we typically try to do like Q24-hour dosing, but for the neonates, depending on kind of how well developed they are and whatnot, you may see more or less frequent depending on that. So there's different dosing schemes which you'll run into if you ever deal with neonatal patients on a regular basis. Did that answer that question?
Mm-hmm.
Perfect. What other questions can I answer for you? Can you relate back to the question to me right now since I don't have it? Yep. Yes. Okay, so eventually you're gonna, yeah, so that's a kind of intermediate step, right? So for that patient, so say they're getting 2 teaspoons every 6 hours, right? Because they're getting it 4 times a day. So a teaspoon is how much volume? 5 mLs, right? Tablespoon's 15 mLs, teaspoon's 5 mLs. But again, this is where a lot of problems come from, because if I use my IKEA spoon from Sweden, who knows how many mLs that is, right? If I use my grapefruit spoon, I have no idea how many mLs that is, right? So that's where a lot of dosing errors end up coming from, is because people didn't really know how to dose this stuff appropriately based on teaspoons and whatnot. But teaspoons, 5 mL. So if they say, okay, I'm giving 2 teaspoons every 6 hours, so I'll say, okay, I know they're getting 10 mLs every 6 hours, okay? So then based on the mLs they're getting, I know the concentration of the drug, which is what? So the concentration of the drug they're getting was how much? It was 160 per 5. Yeah, so if you divide that out, it's 32 milligrams per ml, right? So then I can say, well, they're getting 10 mLs. I'm going to multiply that by 32 to figure out they're getting 320 milligrams per dose, okay? So once I have that dose, then I can divide it out by their weight. So I can do 320 divided by 20, and basically getting 16 mg per kilo is what the patient is being dosed at. Their usual dose is 15 mg per kilo. It's pretty close, so I say, yeah, that patient's being dosed appropriately. Okay?
What if it was 14?
If it had been 14, you're getting a little under.
Yeah, 14 milligrams per kilogram, would that still be okay?
Yeah, because within rounding, because usually within 10% rounding, you're generally fine. Yeah. So that question will come up too, because you'll say like, well, how much are you actually giving your kid? Because in a lot of cases, parents may be underdosing, parents may be overdosing their kids on different meds. So it's like, oh, I can't fix their fever. What's going on? Like, well, you're not giving them enough Tylenol, right? Or not giving enough ibuprofen, and a lot of it can come back to how much you're actually administering. Yes, ma'am.
You said within 10% or the rounding?
Roughly, yeah, that's a general rule of thumb. So like for instance, like we have protocols over at Nemours where like, us as pharmacists, we can round a dose up to 10% before we have to call the provider. That way it just makes it easier for like, say like we prepackage like syringes of like, diphenhydramine 5 ml syringes. If it's like 5.2 mLs, like we just round it, like go to 5. It helps save it seems stupid, but like, it's just one of those things where it's like, it's goofy for a nurse to have to like get 2.2 mLs out of this one syringe and just waste the rest, right? So, yes.
I have another question. With the bathroom calculation you did, you said because it was 2 different drugs, you all typically use the TMP.
Mm-hmm.
So with other combinations, is it a standard for which one you use, or is it?
Yes.
Okay.
Yeah, generally you'll find it's pretty standard. Like, in a lot of cases, you're going to find that like not both of the drugs are active ingredients. So, for instance, like if you're looking at like Unison, right, which is ampicillin plus sulbactam. Like ampicillin is obviously the active component, and then you have the sulbactam, which is doing what? Beta lactamase inhibitor, right? So we always dose that one off of the ampicillin component, right? Or if you're doing like augmentin, which is amoxicillin plus clavulanic acid. Clavulanic acid is the beta lactamase inhibitor. We do it based off the amoxicillin component. But Bactrim, for whatever reason, we always do trimethoprim. I don't know the historical reason for that, but did that make sense how to do those calculations? So be very careful. Make sure you're looking at what I'm actually specifically asking. Like if I'm saying, if the patient gets this many mg per kilo per day, and I'm asking you how much you're going to get per dose, you need to be able to divide that out, or whatever it happens to be, right? Or if I go backwards and forwards, like you need to be able to read those very carefully to make sure you're answering the right question. Okay. Any other questions We'll do some practice calculations here as well. The calculations you can, I made them easy enough where it's very simple math. You can do it with this scratch sheet of paper. You really don't need a calculator. You can do it with your fingers, toes if you need to, wear open toe shoes if you must. You'll be able to do it. It's so easy a pharmacist can do it. Yes, ma'am.
So I've been having a lot of trouble with chemotherapy.
Me too.
It's rough. So
Yep.
you want us to focus on like the specific side effects. So I guess, so for previous, it's like the method of how we treat something.
Yep.
This time point even tailor just towards
Yes, because again,
side effects.
yeah, because with cancer, like there's so many different types of cancers, and there's so many different ways you're going to be. I can't list out every single like, okay, here, we're going to do prostate cancer today, and we just don't have time for that, right? So I really just need to be able to address all the drugs that you're probably going to run into when dealing with a patient on chemotherapy, because either you're going to be seeing them for non-chemo related things, and you have to know, what drugs that they were getting, and at least be aware of that, like. Why are they having such bad diarrhea? It's like, well, okay, because they received irinotecan or something, right? So little things like that you need to be at least be cognizant of, or at least be like, oh yeah, I remember reading about that somewhere. Let me go look that up again, right?
With that, do you want us to know like what's in the combo regimen?
Don't. Yeah, those are just examples of showing you how we can combine different drugs together for different treatments of cancers, but it's really just for illustrative purposes. Really focus on mechanisms of action, being able to classify which drugs fall into which category, specific side effects that are popping up, I say nausea, vomiting, diarrhea, like unless it's a very significant one like irinotecan and diarrhea, like all of them are going to cause that to some degree, right? So just be aware of that, and unique side effects like peripheral neuropathies, if you're running into ototoxicity or kidney damage, things like that. Those are the big things to key in on.
And where the drug is derived from, like in terms of antipsychotics, is that vital information for the mechanism of action?
That's better for categorizing in your head if it's like affecting disassembly or the assembly of the microtubules. I'm not going to ask you which specific U tree that etoposide comes from. Actually, it comes from the apple, whatever. Your taxanes. Any other questions? Okay, so a couple of review slides we'll talk about. You guys remember OB-GYN is on this section, right? I probably won't, obviously all the material is game for being on the test, but I will probably focus a little bit more on the stuff that was not on the quiz, right? So we did a lot of the oral contraceptive stuff, but certainly anything from the HRT section can certainly pop up here again, right? So again, just remember when you're, the rational use for, estrogens versus progestin products, if you should use combos, if you should use progestin by itself, no alternatives. So if I had a lady who could not receive estrogen-based hormonal contraception, like what else could I use? Use a progestin only, right? You guys remember there's some problems with that, such as? But yeah, breakthrough bleeding. Yep. Amenorrhea. Hirsutism, you see that? The ovulation, the anovulation thing can be prolonged and unpredictable, right? So those are big things. So if I didn't want to do that, what else could I use? Use copper. Yeah, an IUD can be a big one. Anything else? Those are pretty much it. There's other forms of prophylaxis, right? You can always use those, or abstinence. Again, that is really the only safe way, right? So just tell all your patients. Okay, and then the benefits and drawbacks of those dosage forms, as we kind of alluded to. So for instance, like using IM, Depo, Provera, or the Depo Medrol, right? So using hydroxyprogesterone, like, yeah, it lasts for 3 months, but again, that could be lasting for longer than that, right? And so it's good for patients with compliance issues, but not those that want to get pregnant on a time frame, right? That'd be things to think about. If a patient misses a dose of their oral contraceptive, what should they do?
Depends how many days.
They're just on 1 day. Just take it again. Good. Okay. If they miss 2 days, 2 for 2 days. If it's 3 days, just start up. Yep. Just chuck it and then restart on Sunday, right? If someone wanted to reschedule their period, what could they do? Yeah, don't take the placebo pills. Keep taking active pills until whatever event is passed, right? Good. And remember, different progesterones are going to have different effects. So again, some of them are going to have anti-mineralocorticoid effects. So you'll see potentially some weight loss or some diuresis from that. Some are anti-androgens, some are pro-androgen. So be aware of all this stuff. Good. Any questions on the OB-GYN stuff? Remember why we use SERMs, right? Because they are going to have different activities in different tissues. So like some of them are going to be better for like osteoporosis while helping to prevent breast cancer, things like that, based on how they work in the different tissues. Okay. We already mentioned this, but things like chemo-specific side effects, like what's most likely to give me pulmonary fibrosis? Yeah, so a lot of your alkylating agents in general can all cause it, but things like busulfan, things like bleomycin potentially could do it as well. Yeah, a lot of the alkylating agents are pretty bad for that. How about cardiomyopathy?
Oh, the Rubens.
The Rubens?
Yeah, Ruby.
Doxorubicin, Daunorubicin, yep. So you guys remember what those are called? And they're antibiotics, yeah, technically, and anthracyclines is another name you can see used for those. Yep, so those would be big ones with that. You guys remember what drug we give to prevent the cardiomyopathies? There's the D. Dextrozoxin. Yeah, so you can do daunorubicin like in a liposomal bilayer. That can help to prevent that, but the actual antidote that we'll use is dextrozoxin. It's like chelating agent, right? Good. Obviously, opportunistic infections are going to be a big thing, very similar to what you saw with like your HIV patients, right? So if you're neutropenic, for whatever reason, you're neutropenic regardless, and so you have to worry about those. Any questions on chemo stuff? It's a lot, but you should at least be familiar with them because you might see them out there. And even if you don't work with chemo on a day-to-day basis, every once in a while I'm even called in to help check chemo, and I hate it, but you know what? You got to do what you got to do. So, fortunately for me, it's a lot of like vincristine's easy to do. Cyclophosphamide is pretty easy to do. Aracy, I don't get into like the really crazy stuff, but yep. Okay. What do we give to prevent toxicity from cisplatin? Amifostine is a good one. Lots of IV hydration is the other big thing, right? Because it prevents what type of toxicity? Yep, nephrotoxicity, absolutely. How about cyclophosphamide? Cisplatin had the A one, that was amifostine. Mesna, yeah, Mesna is going to be the one for cyclophosphamide because that helps prevent what? Hemorrhagic cystitis, right? Because they have a bunch of the acrolein. Again, you could use that for ifosfamide too, right? Potentially. How about methotrexate? What's the antidote? Leucovorin, right? Which is also known as folinic acid, right? It's not folic acid because folic acid can't be used if you have methotrexate on board because you're preventing what enzyme? Dihydrofolate reductase, right? Prevents utilization of folic acid, so that's why I have to get the activated form, folinic acid. Good, and then we mentioned daunorubicin would be that dextroxine. Awesome. Okay. What else can I do for methotrexate to prevent like renal toxicity? So leucovorin helps to, we use that for that rescue component of it, where we're trying to like help replenish healthy cells with folinic acid. But how do we prevent like renal toxicity? How do you prevent methotrexate from precipitating out in the tubules?
Is it bicarb?
Yep, you give sodium bicarb, yeah. So we'll alkalize the urine in order to help make that more soluble, right? So lots of different things we can do to help prevent toxicity. I included this chart here more for your reference than anything else, but just be aware of most places you work will end up having, if they deal with chemo on a regular basis, they'll have these kind of guidelines. If you look at this on the actual, like, not in slideshow mode, you'll see the full chart, but this is a emetogenic potential of antineoplastic agents. All right, so things fall into different categories, and the types of antiemetics you're going to use will differ based on what category it falls into. So, for instance, things like low risk of toxicity, you can see things like low dose methotrexate on here, you know, anywhere between 50 milligrams per meter squared to 250. Probably vincristine is a little bit farther down on the low risk one, but like cyclophosphamide. Some of it is dose based, so you can see if you get in like really high dose regimens, they will go up into the moderate or high risk categories. But obviously things like big doses of cyclophosphamide are here. The other big one, like dacarbazine, some of the other alkylating agents will all be in this kind of really high risk one. And so you'll change what you're going to do based on the antiemetic risk, right? So for like low risk things, we may give like some Zofran. Okay, that'll just be on the order set. For moderate risk, we may give Zofran. We might give, you guys remember, if we go back to your GI lecture, a drug called aprepitant or Emend, right? That was good for that delayed. Yeah, substance P antagonist. Yeah, so that was actually used for that delayed onset of emesis that you can see with some of these agents like cyclophosphamide and whatnot. A lot of times patients who are undergoing chemo, they'll get that anticipatory nausea and vomiting, right? So they know that last time this made me throw up really bad, I'm probably going to get it again. So we give them Ativan or Lorazepam to help kind of diminish that and help them kind of chill out a little bit so they don't have that anticipatory vomiting. And then sometimes we'll use antihistamines as well, so we use things like Benadryl and then onto the regimen. So there's a whole cocktail. They oftentimes will end up getting more antiemetic drugs than they will actually chemo drugs for some of these high risk ones because they can be very, very significant causing that, right? And who here likes to throw up? Terrible. No one wants to throw up. So make sure you get the right regimens for your patients if you deal with them. Okay, moving on. Geriatrics. So you guys know all about polypharmacy now? You guys did that case today? Everyone do well? So, I heard about it. I heard about it through the grapevine. But right. So why do we have polypharmacy? What happens? What causes this? Providers don't talk to each other, right? There's a bunch of them. Aging, they're getting older, they're living longer with disease, so they're getting more and more problems. And again, remember, like sometimes patients will they'll get put on, say, an antihypertensive. Now they're getting dizzy. Okay, we're getting dizzy. Let me go and put you on, like meclizine or something because maybe it's vertigo you're having here. So let me go ahead and give you that. Now they're getting sleepy. Now they're having mental status changes. Okay, and I'm gonna give you a different drug for that. So it can be a vicious cycle where like drugs can get more drugs because of side effects and things. So at some point you need to look at it and be like, okay, let's just stop like half of this stuff you don't really need. You're also considering things like what are their patients' goals, right? Do they have terminal illness where they're gonna be dead in 6 months and they'd rather live, they'd rather live, say 6 months with no side effects versus 8 months with a whole bunch of bad side effects, right? Obviously, we can't predict the future, but a lot of times you have to make those decisions on like, well, what's the quality of life versus the quantity of life, and how do you get a good balance between that, right? Also, looking at evidence-based guidelines, you're normally seeing like more medications being added onto a lot of those. So like being on a statin for history of cardiovascular disease, and if you had a previous MI, you're on a beta blocker, and then you're on an ACE inhibitor for your diabetes, and you're on this for your COPD, and blah, 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 blah. So you can see how very, very easily that snowballs into quite a few medications, and polypharmacy is more the rule than it is the exception for a lot of these patients. Okay, what are some problems with geriatric patients being compliant with their meds? They forget. Visual issues. I never forget. I had this one little old lady. I was doing my rotations in an ambulatory pharmacy, and she probably had 16 meds that she came in on. She was blind as a bat. Like, she would not see the train come to hit her to save her life, right? But she was able to like draw very large symbols on the tops of her pill bottles, and she could look at them close enough to be able to like figure out what it was. And I was like, there's no way you got this all figured out. There's a black star here, there's a red circle here, there's yellow triangle, and I'm like, there's no way you know what all these are. She's like, try me. So she's looking at it, and she's like, yep, that's my hydrochlorothiazide, yep, that's my warfarin, that's my, so some of them are still very much with it. They just may have more physical impairments or sensory input issues than anything else. Some patients have just lost all their mental faculties, and they're just not able to remember things. They're not, they can barely remember their loved ones, much less to take their medication. So again, it can be kind of on either side of the spectrum there. What are some other reasons geriatric patients are not going to be compliant? Money, be a big one, right? This is why we like to prescribe generic meds whenever possible. Again, that can help cost. Like, look at your $4 list, look at your free medication list. You'll have patients who will have their regimens where they go, okay, when I need to go pick up new meds, I'm going to go to this place to get this one for free, I'm going to go to this place to get this one for $4. And so that can be a big cost savings measures for a lot of them. Problem comes up for the pharmacy, though, because if they fill at a bunch of different pharmacies, we don't get to see all their whole list of meds at one time, right? So that can be problematic, just like it is for you guys if they go to a bunch of different providers and they don't give you an updated med list, right? So it can cut both ways from that standpoint. What other reasons? What are some other cost-saving measures that geriatric patients might try if they, yeah, maybe like cut the pills in half, or they'll do it every other day or every third day, right? So it's kind of that intelligent non-compliance where they're not telling you that they're doing it this way, but they're doing it anyway, right? So again, always try to have a very non-judgmental kind of stance with them. Be like, hey, I understand, if stuff costs a bunch, like maybe we can look at your dose, like maybe we need to switch you to something else that is cheaper or whatever it happens to be. But always encourage them being forthright with you. Okay, so what are some pharmacokinetic age-related changes that occur for these patients? Everything's decreased? What is everything? Kidney function? Yep, kidney function is going to go down over time. What are some problems with measuring like kidney function for these elderly patients?
The creatinine.
Yeah, look at their muscle mass. As they have less muscle, they make less creatinine, right? If they have amputations, they make less creatinine, right? So you could be underestimating, right? Because a larger share of creatinine is usually in that denominator. When you're doing your calculations, that's going to bring your value down, right? So falsely low serum creatinine is going to end up giving you a falsely elevated GFR. And that can be overestimating things. You might be dosing them more aggressively than you should, right?
There was one thing that was elevated. It was an alpha something.
The alpha-1 acylglycoprotein.
Yeah.
Yeah, I don't know why that is. It's one of those changes.
What did it do?
It binds to certain drugs. You'll find some drugs bind primarily to albumin, some will go to the alpha-1 acylglycoprotein. Right. So yeah. So again, be very careful with renal function. What's another way you can assess for renal function over time? Urine output's a big one, right? Yep. So again, what's a good urine output? Usually we do it like in mLs per kilo per hour. Is usually how it gets reported out. Usually, for babies or for children, usually we say 1 ml per kilo per hour is good. For an adult patient, between 0.5 and 1 ml per kilo per hour is generally acceptable. Okay. Obviously, that can be affected by things like diuretics or what their hydration status is, but that's usually what we're kind of looking at. Okay, always check the renal function over time. Like, make sure you periodically check that. I can't tell you how many inadvertent toxicities occur because patients are not monitored for that. They're in the nursing home. They get left alone for a while. They get dehydrated. They come in and they get very, very sick off of that stuff. So be careful with that. Okay, so about absorption, any changes that happen here? Why would you see decreased absorption?
Water, body water.
Less hydrochloric acid.
Yep, so they may not be producing much hydrochloric acid, so that can affect absorption.
Body water.
Delayed gastric emptying.
Lower body water.
So you may see the gastric emptying, especially like diabetics have gastroparesis. The body water doesn't really affect the absorption quite as much. Uh-oh. Okay. So what were you mentioning?
I said that they can't excrete it properly, the drugs, so then if the drugs stay longer in the system, or they're like cirrhosis, they can't metabolize the drug properly.
Yes, that's more with metabolism and excretion.
Nutrition.
Yeah, nutrition is going to be a big thing for a lot of these patients. So, again, if drugs require there to be like fat in the system in order for things to be absorbed, that may be diminished depending on what their dietary habits have changed to. Think about like what drug is affected by green leafy vegetables. Warfarin's a big one, right? And so if you ever, go out into a rural type area, what do they eat a lot of? Collard greens, right? So lots of greens. Yeah, so you got to be careful with that. Make sure they're on a consistent diet. Make sure they are, it's not that you can not have it at all or have too much of it. It just needs to be consistent, right? But if they have poor dentition, they can't swallow things right, like all that can lead to issues. And then look at the food-drug interactions that occur. What do you tell a lot of your older women to drink? Not grapefruit juice, right? What? Maybe cranberry juice. What's good for the bones? Yeah. Try to tell them to get some calcium in their system, right? And calcium can bind up all kinds of things. Fluoroquinolones can bind up your Synthroid, can bind up your bisphosphonate. Again, obviously distribution of drugs is going to change a little bit. So as they get older, they lose more muscle mass, but they usually get more adipose tissue. So for lipophilic meds, they end up having an increased volume of distribution versus hydrophilic meds, right?
So I understand volume of distribution, but does that mean that they're going to have more effects of it or less effects of it?
Depends. It depends because basically, if it's something where like I'm giving you an antibiotic and I'm treating a septicemia with it, right? I want that drug to be there in the bloodstream, right, to kill those bacteria. If it gets distributed out to the tissues, it's not at site of action, right? So if I have a higher volume of distribution for a drug, say like I want to get to the brain, maybe that's good. Maybe it'll. You can end up having things that are more lipophilic. They will tend to deposit in the tissues, and you can build up stores of it. So the drugs will have a kind of a longer duration of action than what you would expect because you've got it built up in the tissues, right? Because like again, if you think about like marijuana, like THC, like how long does that stay in the system for? Yeah, it depends on chronicity, depends on how much adipose tissue you have. The more adipose tissue, the higher the dose is, the longer you use it for. The more you have stuck in the fat, the longer it's going to be leaching out for. You have a patient that will, show up with a positive urine screen a month after their last use, right, for a really chronic user. So same thing happens with all these lipophilic meds. They may be sticking around for longer than what you would expect, okay? Okay. Let's see. Yeah, so again, we talked about the kidney clearance, so just be aware of that. Be aware of their hydration status. If they get that pre-renal azotemia or pre-renal kidney injury, like that can be a big cause for accumulation of a lot of drugs. So things like lithium and other kind of water-soluble ones. Okay, so any questions on the Geries? Okay, moving on. We got the Peds. So what are some differences with absorption of meds in Peds patients? Think about the neonates. When I say neonates, what time frame am I talking about?
Less than 1 minute.
28 days of life, yep. Okay, so absorption, is that better or worse?
They have larger volume of distribution because they're bags of water.
Absorption, not distribution.
Yeah, keep bringing up the water.
You got water in the brain, it's okay. So it depends if you're dealing with weak acids or weak bases, right? Because again, when you're looking at acid secretion in the neonate, is it higher, lower? Lower, it's more alkaline, right? Because initially, the first few days, what are they filled with? Amniotic fluid in the GI tract during the first couple days, right? That's pretty neutral. Especially for the term ones, they'll start to develop more acid production earlier than the preterm ones, right? So it may be a while. That's why a lot of the preterm infants end up having feeding issues, right? Just because they're not producing a lot of acid, they have indigestion, things like that. So absorption can be worse initially, and then eventually as acid production gets better, like dissolves like, so weak acids are going to end up getting better absorption as time goes on, right? Versus like weak bases probably have an easier time being absorbed in those first couple days to week, right? Okay, and then distribution, you mentioned they're big bags of water. So for hydrophilic meds, volume of distribution is? Yeah, it's higher, right? It's going to be higher. Lipophilic meds going to be down. Going back to absorption real quick, so what are some other sites of absorption that we can give drugs to? So you can do the skin. So skin absorption is higher or lower?
Way higher.
A lot higher, right? Did I ever tell you the story about the little boy who got the ketamine cream on him? Okay. I might have. So just real briefly, so basically we had a kid that got brought into the ER. He was brought in for being somnolent. They ended up having to intubate him. Kid ended up doing okay eventually, but the thing that precipitated that was Dad had chronic pain issues. He had a custom compounded cream that had ketamine, amitriptyline in it, all kinds of other stuff in it. Baby had diaper rash. It was just after a bath. So hot skin, nice and flush, diaper rash, lots of blood flow to the area. Slap on this cream and right into an occlusive area covered by a diaper. Just a perfect disaster for this kid to absorb all this med, right? And so we can measure detectable levels of ketamine metabolites afterwards. But just be aware, kids absorb things much better through the skin initially because they just don't have a stratum corneum to prevent that. How about intramuscular absorption? Pretty erratic initially in the neonatal period, right? Because they don't have, because you think about where they're trying to supply blood flow to, they don't need to move around a whole lot. So the muscles are going to be erratically perfused, and then that's where you're going to get kind of erratic absorption. Okay. How about the rectum? Great absorption, right? So that's where we like to do a lot of acetaminophen. That's where we'll do. This is probably the main drug that we end up using rectally for absorption, but it's very vascular, lots of good blood flow. You just have to remember what? They poop it out, yeah. So again, anytime you eat that kind of that feeling of fullness, like you're going to have that urge to defecate. So certainly lots of cases you put a suppository in, they'll poop it out 2 seconds later. You need to consider redosing them in those situations, right? Okay, so I mentioned distribution. How about metabolism? How does that differ?
Depends on their age.
Yeah.
Does he have another CYP in the beginning?
They have mom's creatinine around. Yeah. So that'd be important for elimination. For metabolism, again, it's going to take time for their enzymes to start ramping up, right? So things start to appear at different rates. So again, you may have, sulfation pathway is very good at birth, right? Versus things like a lot of your CYP enzymes take time before they really start to creep up. Some of them will be good to go in a couple weeks, some will be a couple of months. It just depends. And so most of your dosing references out there are already taking that into account, right? So say, kids 3 to 6 months, we're going to dose it this way, versus if they're 0 to 3 months, it'll be this dosing, right? That takes that into account. And the excretion, how does that differ? Right, so the more preterm they are, the more underdeveloped the kidneys are going to be, decreased quality and quality of the nephrons. So that can take time to get back up to, about when do you get to like normal adult levels? About 6 months, yeah, 3 to 6 months or so. Yeah, it takes a little bit of time, but around 6 months, you should be pretty close to what an adult would be getting at. And again, that's why we can't really, when we're doing renal function assessment for neonates, we don't even look at their serum. We look at their serum creatinine, but for the first couple of days, we're measuring mom, so that's not going to be useful. But there's really no good GFR calculations like you see for like children or for like adults. So we only go exclusively off the urine output, right? So we're measuring diapers. If they have a catheter in, we'll measure that. Okay, and then drug dosing calculations, your guys' favorite part. All right, so let's do some. These are harder than what's on the test. Okay, FYI. Answers are in the notes section. Don't look at that yet. We're gonna do it together. So I'm getting out my calculator, not my phone. I'm not looking at Reddit. I promise. Huh? Fingers and toes. Well, these are harder than what's going to be on the test, right? So these are not going to be easy round calculations, okay? Okay, so let's say we have a 22-pound patient being treated with sulfamethoxazole trimethoprim, Bactrim for UTI. The dose is 8 mg per kilo per day of trimethoprim divided BID. And again, this is a big problem why we run into dose errors in the real world, is because references will have things in mg per kilo per day or mg per kilo per dose, and people don't do the conversions right. Huh?
Why don't they just do it the same way?
It'd be nice if they did, but yeah. So one of the problems we actually ran into at Nemours when we were first starting to open is like in the ER, are you frequently ordering, so say like you want a patient to get an antibiotic dose in ER, you're just going to write for a one-time order, right? Well, the problem is the EPIC, which is our EMR at the hospital. You guys probably run into EPIC at some point during your clinicals. All of the antibiotics were dosed in mg per kilo per day. So they put in their dose normally, like say Rocephin, I'm going to do 50 mg per kilo per dose. They would end up doing mg per kilo per day and end up getting it goofed up because it was thinking like, well, you want to do this per day, but you're only doing it once. They keep getting all those errors out. So then the docs are having to like go through and actually figure out what the actual milligram dose is going to be, and it's kind of a hassle. So again, it's one of those things where you have to go back and constantly re-update things and make sure it's going to work for your providers in their traditional workflow. So again, this can be a common error you're going to run into, especially if you're doing it on the old-fashioned way and actually doing the math in your head, right? Anywho, okay, so we have a 22-pound kid. They're getting 8 mg per kilo per day of trimethoprim divided twice a day. The suspension comes as a concentration there. how many mLs should the patient receive per dose? So what's my first step here? Yep, convert pounds to kilograms. That's the number one step. 2.2. 2.2 pounds for every kilogram. So I'm going to take 22 pounds divided by 2.2. Kid weighs 10 kilos, right? I'm not going to make you do that conversion on the test, but I did this here to illustrate that point. If you goof up your conversions, you can either double dose or half dose your patients, right? Watch your pounds to kilo conversion. Okay. Anyway, so this kid's 10 kilograms, which means how much trimethoprim is he getting a day? Right, so 80 milligrams, so 8 times 10, right? So he's getting 80 milligrams per day, and that's divided twice a day. So I know that per dose he's getting 40 milligrams of trimethoprim, right? And so then that means how many mLs should he be receiving per dose? 5 mLs, right? Perfect. Pretty easy, right? This is harder than the test. Yeah. Huh? Yep. Absolutely. Okay, so first step, convert pounds to kilos. Okay, so we got that. Next step, figure out what the dose is going to be for that patient. So we do 10 kilos times the 8 mg per kilo per day. Okay, so I know per day the kid's going to be getting 80 milligrams of trimethoprim. Okay, now that's per day, so I know he's getting it twice a day, so I divide that by 2. So I know that per dose he's getting 40 milligrams of trimethoprim. Okay, so then I go back to my concentration and I just divide that out to see how many mLs they should be getting. So for this this suspension, it already comes as a 40 milligram per 5 ml suspension. So I just divide that out and basically end up being 5 mLs. Okay. If that had been a different number, I would have figured out how many milligrams of trimethoprim there are per ml. So I would do 40 divided by 5, which is 8, right? So I would do 8 milligrams, and I would just take my final dose, so in this case 40 milligrams divided by 8, and you get 5 mLs as well. And you can make your own practice problems with this one, right? Like just go to any kind of drug reference, like go on to, I'm not sure if you guys have access to Lexicomp or not, or like ClinPharm, but go just look up any antibiotic and like look at the dosage form that it comes as a suspension, and just make up your own practice problems, right? And you kind of work them out with each other, because practice makes perfect when it comes to this stuff. Okay? Unless you guys like don't like each other, and then just practice on your own, or send me a practice problem and I'll work it out with you. Anyway. Okay. Next, we have a 43 kilogram patient who is presenting with a trauma and hypovolemic shock. You want to give him a fluid bolus of NS and then start a patient on a continuous infusion at 2 times maintenance. How much NS should the patient receive? So how do I figure out my bolus? 20 times, which is 20 times 43, 860. Absolutely. So that's your bolus. And then how do we figure out what their maintenance rate is going to be? 421. So what does that mean? So yeah, so it's 4 mLs per kilo per hour times the first 10 kilograms. Then it's 2 mLs per kilo per hour for the next 10 kilograms, and then it's 1 ml per kilo per hour for every subsequent kilogram. Okay. So for this patient, because they're 43, for the first 10 kilograms, he's going to get 40 mLs per kilo per hour. For the next 10, he's going to get another 20. Right? So now how many kilograms do I have left? 23. So I'm going to do that 60 plus 23. So his maintenance rate is 83 mLs an hour. But I want to run it 2 times maintenance. So then it'd end up being 166. His hypovolemic shock. You gotta take him up, right? So that's why sometimes you'll see like start them at 1.5 times maintenance, start at 2 times maintenance, and so being able to do those.
So you just multiply by 2?
Yeah, you just multiply that 83 by 2. Until the patient's perked up. Huh?
Oh, so it's not like a time thing, like it's until they get to
Yeah, it depends. Like you're going to go back and reassess that patient. You say, okay, like their shock is resolving, they look a lot better, they're perfusing well. Let's go ahead and cut it down to 1 times maintenance. Yeah. So again, it's not like a set and forget it kind of patient. Like you're going to be watching them pretty close. Yeah. Because again, what's the problem? Giving too much fluid. Where's it going to go to? It's going to go to the lungs, right? Not the brain initially. The brain can regulate that a little bit better, but the lungs is kind of the big open airspace for water to go to, so you don't want to do that. Okay. So let's do the same thing with an 18 kilogram patient. So what would their fluid bolus be? 18 times 20 would be 360. Yep. And then what would their maintenance rate be? So 40 for the first 10 kilograms, and then 8 times 2 would be 16. So it would be 56 mLs per hour, and so then we'd want to multiply it by 2, so it would be 112 mLs per hour. Okay. Oh, well, I probably goofed that up then. So there you go. You guys, we'll have the recording for posterity's sake. Does that make sense so far?
Yeah.
Everyone with me? If not, you can make up practice problems pretty easily and just kind of just do it a couple times and you should be good to go. Okay, next, let's look at a 6-kilogram infant who's requiring Zantac therapy for their GERD symptoms. The dose is 4 mg per kilo per dose twice a day, and the solution comes in 75 milligrams per 5 mL. How many mL should the patient receive per dose? So what's my first step? So I'm going to do 6 times 4, so that means 24. Y divided by 2? Nope. Because look, it's mg per kilo per dose. Be very careful. That was the trickiness. So I know I'm getting 24 milligrams per dose of Zantac for this patient, right? Everyone with me? So I do 6 times 4. It's 24, and that's mg per kilo per dose. I already know that's what they're getting per dose already, right? The BID is kind of irrelevant at this point. So anyway, so then my solution is 75 milligrams per 5 mL. So that's how many milligrams per ml? It's going to be 15 milligrams per ml. And so I would just take 24 divided by, yep, so 24 divided by 15, which is 1.6 mLs, right? So I would do 1.6 mLs for that patient and give that to him twice a day.
But these kind of require calculators for some of us?
These do. The ones on the test, super straightforward. It's like multiplying by 10 or dividing by 10. I'm sorry? I can ask them to. I don't even know if they have that capability, but I'll ask them. I'll say, hey, can you give them a calculator? But you know what? I believe in all of you. I believe you guys can do it. Okay, everyone with me so far? Okay, next, going to the prescription writing. So, what's required to be on a non-controlled prescription? So, isn't that interesting, though? You saw the patient's name was not on that list of things that are required. Isn't that weird? You're going to do it anyway, because you should, because if I got a script that had no one's name on it, I would not fill that script, right? But according to the actual law, if you look at the Florida statute, it's not actually nowhere on there, okay?
What if your patient doesn't want to give their name, because they're, for whatever reason, like, okay, so say your patient needs to go and pick up her acyclovir, like, what if she doesn't want to put her name on it?
Well, I mean, do you accept patients who don't, if they came to you to be treated for their herpes or their HIV or whatever, like, you still have to make a medical record on them, right? You still need to have their name. They'll usually get like an MRN or something, like if they're within, it depends on the kind of system you're working with. Like, so for all patients at Nemours, everyone gets an MRN number associated with them. That's always like their number. Now, certainly you can have certain patient de-identifying things. So, like sometimes if like we have like a famous patient who comes in or their parents are famous or something, we'll actually like block out their name on, like if you're just looking at like a census list for the hospital, they would actually block out that name. But once you go into the chart, then it would be there, right? So at some point you have to have access to that information, right? And if we're doing things like from the pharmacy side, like, are you filling other prescriptions and maybe interacting with this? And like we need to be able to check for that sort of thing to make sure we're doing our due diligence from that standpoint. So we always, we treat it just as private as everything else. I don't care if it's HIV med or if it's for your GERD or for your erectile dysfunction or whatever it happens to be. We treat it all as private because we all follow HIPAA, right? So from that standpoint, yeah, because so if I got a prescription and it just so say like I got transferred to me electronically, there's no name on it, no date of birth, no address, and then someone came up like, hey, I came to pick up that script. I'm like, well, I don't know who you are, I don't know who the script is for. I wouldn't hand that out, right? I would definitely call the provider back and be like, hey, I need a name for this. Good question though, yeah, because I mean privacy stuff comes up all the time. We have a lot of sensitive meds that get filled, so you have to consider, especially like from our standpoint, if you wanted to counsel a patient about something, or like, hey, who's here to pick up their Zidovudine? You don't want to do that, right? You want to be a little more tact. So you say, Mrs. So-and-so, can you come to pick up your...
Well, I was listening to that and realizing that, and I'm like, when it's kind of like going to the ATM, right? Like, you're not supposed to be all up on the person in front of you, but sometimes at Publix or CVS, there's like...
You'll overhear all kinds of stuff.
17 people that are waiting and they're crowding around you.
Yeah, so most pharmacies should have a like dedicated like counseling area where you can go to and keep them separate. Do they use them all the time? hard to say, yeah. But I mean, you're not gonna be like, got your oxycodone right here, like we don't shout stuff like that out, but we'll got your Viagra ready to go for the weekend. So, like we have a little bit more tact than that usually, or just like if patients at your clinic, you're not like, I got your HIV results back. You're negative. For what it's worth, so we try to be a little bit more private with their information and whatnot. But yeah, certainly, I mean, you overhear stuff all the time, not even at the pharmacies, but like in the hospital, like people are very loud about their own personal information. Like you think they do a little bit better job, kind of keeping their own stuff private, but man, you'll get an earful. Just you'll hear it. Anywho, okay, so what are some other things that are necessary to have on the script? The dose. You want a dose? The date that it was written. Absolutely. Because, again, how long are these scripts good for?
A year.
1 year. What are the exceptions to that? Yeah, so controlled substances, right? So for a C3 through 5, 6 months, right? So I can get a total of 5 refills on that. So a total of 6 months worth, right? But after 6 months, it's no longer good. And then for the C2s, you can write up to a 3-month supply, basically, and so what frequently happens, and I've already mentioned it in the lecture, but for a lot of patients who get their ADHD meds, so we see this very frequently for like kids with their Vyvanse and stuff like that, is the mom will come up and they'll have 3 different scripts, like this one's for January, this one's for February, and this one's for March. Usually we let the parents kind of keep hold of the scripts, so that way they don't come back and say, well, you're holding my script, and I'm like, I don't have it anywhere, and then you're screwed because you have to go back to the doctor to get another one, right? So we don't like to play that game, so we let them hold on to those until, but they are post-dated to say, like, hey, this was written on this day that I actually wrote this and signed it, but do not fill until, and so we follow those instructions, okay? So again, shorter time frame for when those are good, but for most non-controls, all non-control prescriptions, 12 months is how long it's good for, okay? What else do I need on there? Signature, yep. Can that be an electronic script or signature, or can it be rubber stamped? Yeah, for everything except for C2s, right? For C2s, I have to have a handwritten script, signature on there. But a lot of times if you have things that are faxed over, or a lot of things are generated on the computer, it'll say electronically signed by Dr. So-and-so, right? So those are acceptable. C3 through 5 can be transmitted electronically. Sometimes it will get called into us. Again, we're writing all of that down to a paper script for our records that we keep. Yeah, so that's the main things.
Like the number and refills as well?
Yeah, so you want to have how many refills are available. Because if you don't put any refills, then we assume it's 0, right? So that's one of those things. But yeah, certainly the quantity to dispense is needed on there.
And you write it out too?
For the controlled substance, yeah, you need to have a numeric and a written out thing.
For every...
Yeah, for non-controlled stuff, you can just have like you can write number 30, and that's totally fine. Yeah. You don't have to put an indication. That's a good practice to do, right? So for some things, it's kind of obvious. So like insulin for, like obviously it's going to be for diabetes, right? But yeah, so if it's something like clonidine, like is it for ADHD? Is it going to be for hypertension? I don't know, right? And that can be important when we're looking for like therapeutic duplications, if we're looking for interactions, things like that. We want to make sure that makes sense, right? Also, like, if you're writing for things outside of your practice, that can sometimes help us out. Because sometimes you'll have docs or providers who are writing for things that I may have never seen, but makes total sense from their perspective, which is something I might call on anyway. But if you write an indication, that kind of helps to alleviate some of those calls.
So, insulin is a anabolic steroid, I guess?
Technically.
So, like if a patient is new or whatever and they just want it for that, and they don't really have diabetes 1, does the doctor have to like test them for any reason, or can they just start doing this?
I mean, whoever's the prescriber is the one that makes the ultimate decision. I mean, no, I don't think anyone.
Say I have a history of DM1.
They probably want to look at your records, I'd imagine. I can't. Yeah, I wouldn't. If some patient came up and said, "Hey, I'm on such and such." Now we'll have some cases where there's some legal allowances for us to give a vial of insulin to a patient without a prescription, right? Because that's one of those like life-saving medications, right? So there are some provisions that we can like dispense out a vial of that in supplies and things. But in general, like it's one of those things where you probably want to have some history of it, or at least look at the records before you're.
It also costs $700 a month.
It's a little expensive. It's a little expensive. Yeah. Yeah, so it depends on what, because you'll find that some pharmacies will do they'll do their acquisition plus a certain dollar amount on top of that to cut costs for the patients, but it just depends. Okay, so you guys are good on requirements. Again, they have to be hand signed for C2s, right? What are some other examples of C2s? Yeah, so just or other instances of C2s you might write for. Marijuana is C1. Yep, still C1 technically. Hydrocodone was moved to C2. Oxycodone, morphine, hydromorphone, yeah, all that good stuff. Right, so those are the things you should be really kind of keyed in on from that standpoint, yeah. And then, yes, the counterfeit proof paper, right? So if we got someone brought in their script and they came in and said void, void, void all over it, I'm not going to fill that, right? And you'll be surprised the dumb stuff that people will try to do to, it's like, oh, my dog ate the original, so I've photocopied it beforehand. No. Nope, not going to work. I'm trusting to a scary extent, but there's a lot of things I'm not going to lose my license over, and that's one of them. Yeah, so that can be a big thing. Also, what other requirement is there for controlled substance prescriptions that is unique to you guys?
Oh, we need a doc.
You need your DEA on there. You need to have your practice, like your location and your name on there as well, right? So you have to have all that information available. Just remember that, like, to make sure to have the DEA number. Most of the times, when you apply to get those script pads, they will come back already with a lot of the information on there, right? So you can kind of customize those. Like, we have blank ones that we have that just say, like, Nemours Children's Hospital, and then, like, the person would write in their DEA and their name and everything. That's for, like, if we have a downtime and the system can't generate a script for you, they can handwrite it. And I'm sure I mentioned it, but I had a provider where Epic went down, and the doc's like, well, I need to write a script for this. And I'm like, well, go ahead and write a script. Here's a pad. And they're like, I've never written a paper prescription before. Like,
It's just like typing it.
Exactly. But when the system, that's the thing. You press the button and it generates everything. You say, I want this many mg per kilo per day. I want to give this much, and boop, done. My name's already on there. It's all the refills are done. All the stuff's already done for me. But you have to actually do it to handwrite it. That's a whole nother story. So, and it's very easy for them. Huh? Yep, yeah, and that's the other big thing, is make sure that legibility is a big thing too. So, okay, so any other questions on the actual script writing process? Okay, let's do a few practice ones.
We do.
You do oxygen?
You said you want to do a practice. How do we do oxygen?
That would probably go to a medical supply store. So I don't know what the different requirements are on that.
Well, I meant like 2 liters nasopania.
Well, if you're doing like an inpatient order, those are different. Those have like kind of different requirements. This is just specifically for, like, prescription you're filling at a pharmacy, right? But a lot of inpatient orders, you can lose a lot of those requirements, right? Because a lot of times if you have privileges to be writing for different things at hospital, like, you don't have to worry about DEA number because that's kept on file somewhere, right? We know that, okay, you're part of the orthopedics department. We know that you should be prescribing these type of meds. You're credentialed for these type of procedures, X, Y, Z, and so it kind of limits you from going outside of that in a lot of cases. But yeah, so you can write, like, oxygen via non-rebreather, 2 liter, whatever, Yeah. But again, I don't write a lot of orders like that, so I like drugs. Although oxygen is a drug technically, and a poison if given at the wrong amount. Okay, so anyways, let's do a couple practice problems. So how would you write this prescription? So do you guys have paper you can practice with? Or some sort of...
Are you going to check our papers?
I'm not going to check your papers, but we can at least walk through it, right? Okay, so John Doe has a date of birth of 1/1/79. Should you include date of birth on prescriptions?
Yeah.
You should, as a general practice, so that way we can, because there's probably a lot of John Does out there, right? Also, if you include their address, that is very useful as well, because then we can cross-reference that. Okay, so we've got date of birth on here. He's got no known drug allergies. Some people include drug allergies on the script. A lot of computerized programs will do that automatically, which is nice, but that is not a requirement. It's just helpful for us on the pharmacy side. And he needs a prescription for HCTZ. So how would you write that? You can check Hippocrates, so go ahead and check Hippocrates. What's a good dose for HCTZ? 12.5? It's a wimpy dose. I really want to treat these guys hypertension. 25. Okay, so let's do HCTZ 25 milligrams. Should I use HCTZ? Technically, probably shouldn't. A lot of people will write that anyway. That's ubiquitous enough of an abbreviation. But what is the problem with abbreviations? They can be confused for lots of other things, right? So that's why we moved a lot away from using things like QD, because QD stood for.
QI. But
or yeah, it stands for every day, but we don't want to use that anymore because it could be misread as QID, it could be misread as OD, which would mean it'd be getting the eye. So that was very error prone, so that's why we write daily, right? Or once a day, right? So those are all acceptable alternatives to that. Okay, so you'd write, John Doe's name on there, you'd write his address, you'd write his date of birth on there. If it's pre-done, like you'd already have your practice on there and your name potentially. And then what else would go on there?
Dispense 30 times.
So you do HCTZ, 25 milligrams, PO, which is by mouth, daily. So you don't have to write times 30 days. What you can do is in the quantity to dispense, or you can write quantity number 30, right? So that's usually what people end up usually putting it is the quantity number 30. Or if it was like a twice a day med, quantity 60. And that makes sense to us, right? You could write BID quantity 60, and we know, okay, that means you want it twice a day, right? So enough to write the month.
You write out the word quantity? You don't put like a number?
Most people do like QTY, or they'll do a hashtag, something like that. Isn't it sad we all say hashtag instead of pound sign? Yeah, so they'll write a little hashtag, and then they'll say 60 or 30, whatever it happens to be, right? What else should go on there?
Do we have to write like swallow one tablet every morning, or
So you can be as specific as you want, right? One of the problems that we run into is when these just say uses directed, because what's the problem with using uses directed?
they don't get directed?
They don't know what directed.
Right, so it depends. Sometimes that's okay, right? So if you have like a methylprednisolone dose pack, right, that's pretty self-explanatory. All the instructions are already on the pack, right? So just that uses directed, you're taking how many ever pills on the first day, second day, third day, and that's easy enough, right? But a lot of times if you have an older patient who maybe they are forgetful and they don't remember what you told them to do at the office last week, if they look on their bottle, it says uses directed, they're not going to know what to do, right? So that's where I like to be specific. So if you want to take one pill by mouth, QAM, or every morning, that's perfectly acceptable. Okay, or you just do one pill daily, one tab daily. That's totally fine. Okay, and then what's the last thing we need on there? Yeah, number of refills, right? So how many refills could I write for this script? I could do 11, yeah, because it's a non-controlled script and it's good for the whole year. I could do this fill plus 11 refills. That's totally fine. If I wanted to do it as like a trial med, I could do it for 3 months. You can do whatever you want, right? But you could write up to a totally year's worth of meds. Okay, and then finally, what would you have on there? Your signature, right? Usually you'll have like your NPI number on there as well. That's another way we can like look up providers and stuff to make sure we have all their information accurate. DEA is usually on those scripts kind of pre-done as well. It's another way we can identify. There's actually, you guys ever covered DEA numbers before? You can actually use a DEA number. You can actually, if you have the name of the provider, the way the numbers come out, there's a formula you can do to make sure it's a valid number. I don't remember off the top of my head because we never do it anymore. Huh? Yeah, the same thing as like a driver's license number. There's a lot of codified information on there. But yeah, so you can actually go back through and make sure it was a valid DEA. Until some people figured out like, okay, this is how I can fake a DEA number, so I can go ahead and write my own. I'm making my Joe Schmo doctor for my 200 Percocet. Yeah. Okay. Anyway, so the other thing, if you're writing for an as-needed medication, what's important to include on there? What's as needed for, right? If you put as needed, patients may not realize, like, okay, well, should I use it when I'm having a panic attack, or should I use it when I'm having pain, or whatever it happens to be. Be specific. The more specific you can be, the more, the better information is going to be on those pill bottles, and the patient gets it, the more likely they're going to use it appropriately. Okay, good. Okay, Jane Doe, she wants to pick up her script for birth control. Yes, John Doe's wife. It could be his sister, it could be his mom, for all you know, who knows? That would actually be a very odd relationship. She's a time traveler. Okay, so anything different for this script? So yeah, so this might be another one where like uses directed is probably acceptable because it's very clear how the patient's supposed to take it. Very frequently you might write a brand name on here, but when you write brand names on scripts, what is likely to happen? It gets substitute. Yeah, so if there's a generic available, we'll automatically substitute that out. It's law that we can do that because it provides cost savings to the patients, right? So we'll substitute that out unless you write. Right, so you have to write dispense as written, right? So if you write like Synthroid, you say dispense as written, I have to give you brand name Synthroid. If I don't have it, then I have to order it or whatever. The patient can't pick up their med, okay? That's important to remember. You'll see DAW, that's another thing you'll see on there. Just dispense as written. Yep. Right, so a lot of people write like the brand name of whatever birth control they want to write for. If there's a generic, we'll just swap that out. It's just easier to write Yaz instead of drospirenone plus ethanol estradiol and whatever, blah, blah, blah. Because especially like triphasic ones and stuff. It'd be too hard to kind of write the dosing out on that one. Okay, and again, how many refills could I write for? You could do up to 11, right? You want them to come back? You could, yeah. So that's perfectly valid. You could do that as well, right? Yeah, because you could do a full year's worth, right? Generally, it depends on insurance coverage. I mean, I could dispense potentially all 11 refills right at that one time if you wanted to pay out of pocket for it, right? But if they have like insurance coverage, there may be provisions on how much they'll fill at a single time. Usually there's things in there they can fill 3 months worth. And so we would just take off the extra refills on there if we were to do that. Or you could write it as, quantity 90, take as directed, quantity 90 with 4 refills or 3 refills, right? That way you still get the year mark. Okay, and then how about Jimmy Doe? That's her son. Jimmy Doe has got no known drug allergies, and he has a prescription for an amphetamine-based ADHD medication. So what do you want to prescribe him?
Oh,
You need 2 seconds.
they have to come to the office.
Breaks.
Wait, so they're
First of all.
young, so they're not an adult. I'm gonna give him Adderall.
You want to do Ritalin? You do Adderall? Yeah, man. Have you seen Jimmy Doe? He's running around. He's already been tearing down all the stuff in your office. Jimmy. You seen Jimmy Doe? He's going crazy, right? He's already torn up half the pharmacy now. Walgreens looks like it's been blown to bits. Okay, so anyways, we want to give him an amphetamine-based medication, so that means it's going to be what schedule?
2.
Automatically going to be Schedule 2. All amphetamine-based products are Schedule 2, right? So if we want to do like Vyvanse, if we want to do Adderall, Ritalin, whatever it happens to be, again, if you write for the brand name, we're going to sub it out if there's a generic, right? Vyvanse only has Vyvanse, so that one would end up coming out as a brand name. And if I wanted to write, how many refills could I do on this one?
Up to 3.
0 refill. I cannot do refills on C2s. I can give them 3 scripts.
But you have to put on it, do not fill.
Until, yep. So do not fill until 1/1/17, 2/1/17, 3/1/17, whatever it happens to be. You could write all of that onto one script. You could do 90 days worth as like a one-time fill, but that's uncommon. We would do that. Typically, we'd have the patients come back every month. And again, the benefit of that is like the patient's not coming back to you every single month for a script. You may do that in the initial just to find out what's good for them, but eventually you can get to a point where you can give them multiple months. Okay. And again, can I fax this one over, or can I call it in? Has to be hand signed. Has to be on the counterfeit proof paper, right? But the birth control, that could have been called in. The first one could have been called in as well. It could be faxed over. It could be carrier pigeoned over. Whatever. It doesn't really matter, right? But this one has to be hand delivered to us. Okay. Because that's kind of thing like when we saw the outpatient pharmacy at Nemours, a lot of our scripts came through from the surgery department, right? So like kids would get like their TNAs done, or they would have like their get tubes placed or whatever. So they'd often write for pain meds that would come down to us, along with like ear drops and stuff like that. And so we could get the ear drops electronically, and that would automatically be in our system, and it was nice because that all transferred over. But all of the pain med scripts had to come through the tube, had to be on the paper, already signed by the doc and everything. So can I pre-sign prescriptions?
No. You say a priest?
Huh? Yes. Can a priest sign a prescription if he has a valid medical license? Yes. No. Can you pre-sign your prescriptions? You may not pre-sign. I talk a little fast. I'm aware of this. Yes, you may not pre-sign scripts. You need to do it at the time of actually filling it, right? No predating. You have to do it the date you actually wrote it. Okay? Any questions on script writing? So that way one day when your computer system goes down and you have to write a paper script, you're like, I know exactly what I'm going to do, and write it out. And no pharmacist will ever call you up about bad orders. Okay. Any questions? Any other things I can answer you for the test? One of the answers may be C.
They're all going to be C.
All the chemo.
All the chemo drugs will. No, I'm just kidding. I'm not gonna commit to that. I'm attempting to make it equally distributed. I'm having to write a lot of new questions, so I'm trying to evenly distribute it out. I can do what?
Yeah, let's put more OB questions.
For more OB questions? Okay, I'll see what I can do. I'll take that under advisement. How about that?
It's already made, isn't it?
I'm still working on it. So okay, so unless you guys have any questions, when's the test? Is it Wednesday?
Wednesday.
Next Wednesday. Okay. Good luck. I will answer emails as long as I can up until a reasonable point, after which, good luck. Again, if you guys ever need anything, like, feel free to email me. You guys have my email address. If you're out there in clinicals and you have like, hey, I wonder about this, feel free to write me back. You guys will be my students for long after this class is over, so just feel free to utilize that. Listen, I'm trying to be heartfelt every once in a while. Anyway, I will see you guys around. If you rotate it into Moore's, I'll be in the ED Friday nights, and I'll maybe see you then.